Welcome to an interactive webinar, See One, Do One, Teach One, Reimagining REI Training Programs to Expand Access to Care. I am Sarah Ramaya, Curriculum Design Strategist and Webinar Coordinator at ASRM. Our moderator for today's session is Dr. Chris Herndon. Dr. Herndon is Assistant Professor and Medical Director in the Division of Reproductive Endocrinology and Infertility in the Department of Obstetrics and Gynecology at the University of Washington. He is past chair of the ASRM Access to Care Special Interest Group and involved in local, state, and national initiatives to improve access to care. Dr. Herndon received his medical degree from Yale University, residency training at Brigham and Women's Hospital and Massachusetts General Hospital, and fellowship at University of California, San Francisco. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other reproductive professionals. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. Please note, all attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the chat window at any time. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn the presentation over to Dr. Herndon.
Thank you, Sarah. On behalf of the American Society for Reproductive Medicine and the ASRM Access to Care Special Interest Group, it is my pleasure to welcome you to our webinar, See One, Do One, Teach One, Reimagining REI Training Programs to Expand Access to Care. In 2015, ASRM launched the Access to Care Initiative as a collaborative call to action for universal access to reproductive care through education, research, clinical innovation, and outreach. Our webinar today is part of a series by the ASRM Access to Care Special Interest Group to help educate and inform health professionals on barriers that limit access to care and initiatives to address the wide gaps in access to care that exist today in our communities. OBGYN residency and REI fellowship programs are centered at academic medical centers, U.S. military medical facilities, and community-based hospitals that often serve as access care points from patients from underserved communities. With proper development of infrastructure and curriculums, these centers create an opportunity for trainees to directly participate in and provide care for patients from disadvantaged groups who may otherwise not have access to infertility care. Many training programs, however, lack the formalized curricular and clinical structure to optimally equip trainees with the knowledge and skills needed to optimally provide care in these settings. Enhancing training and clinical experience will not only strengthen REI education and better prepare graduates, many of whom will go out to provide care in resource-limited settings or where there is not a subspecialist REI, but also serve to help narrow the profound disparities in access to care that exist today to underserved and marginalized groups. Our webinar is entitled See One, Do One, Teach One, Reimagining REI Training Programs to Expand Access to Care. We have a wonderful panel of speakers today, all of whom are current trainees or recent graduates. Our panelists will speak to the scope of the problems, barriers in access to care, help us think about the biases that we may bring to care, as well as the important role trainees can have in helping to improve access to care today. It is my privilege to introduce our panel. Our first speaker in our webinar is Dr. Tia Jackson-Bay, a recent graduate of the University of Illinois at Chicago REI Fellowship Program, and who is currently at the Brooklyn office at RMA, New York. Dr. Jackson-Bay, who is a member of the ASRM DEI task force, will share her perspective on the scope of the problems, the disparities that exist today in communities, and barriers that limit access to care. Our second speaker is Dr. Holly Mayer, who is a recent graduate of the University of California, Los Angeles REI Fellowship Program and is a member of the ASRM Education Committee. Dr. Mayer, who is a former public school teacher and holds a master's in education, will discuss building curriculums to better provide care to underserved patients, as well as addressing biases that we may bring to care as healthcare providers. Our third speaker is Dr. Jacob Christ, one of our outstanding OBGYN residents here at the University of Washington. He is currently applying to REI Fellowship. Dr. Christ has worked to develop patient education materials for our resident REI clinic at Harborview Medical Center here at UW that provides care to the underserved. Dr. Christ will speak on what trainees can do to optimize patient care in their clinics and strategies to optimize the clinical management of infertility in challenging resource-constrained settings. Last but not least, our fourth speaker, Dr. Michelle Vu, is a second-year OBGYN resident at the University of Rochester who's passionate about access to care and recently gave presentations at ASRM webinars on diversifying reproductive medicine. Dr. Vu will talk about the vital role of advocacy, how trainees can become involved and make a difference in their communities. Our webinar will close with a 15-minute question and answer session where our panel will answer your questions that can be submitted in the course of the webinar. The slide deck and informational handouts, which includes curriculum tools, clinical resources, and advocacy tools, are available for download from this webinar. Also, please take a moment to fill out a survey at the close of the webinar. There is a link to the survey to sign up and to join and volunteer for ASRM, including the Access to Care programs. It is my pleasure to turn the webinar over now to our first speaker, Dr. Jackson Bay.
Thank you so much, Dr. Herndon. I'll be talking about barriers to accessing infertility care. So infertility is a medical condition, a disease, which knows no bound of geography, nationality, sex, gender, race, religion, or sexual orientation. So if you take nothing else away from this webinar, let it be this, that infertility is a disease. The information we present is based on the premise that all persons have a fundamental right to building their family. And if their reproductive organs are not functioning as intended, each person has the fundamental right to evaluation, diagnosis, and treatment for the condition. This understanding is necessary to address existing and significant gaps in access to infertility care. With that being said, understand that infertility is also very common, affecting up to 180 million worldwide and ranking 5th among sources of disability globally. However, infertility struggles to be acknowledged and prioritized in the medical landscape, both in the US and abroad. Comprehensive fertility care includes 3 basic tenets: evaluation for causes of infertility, arrival to a diagnosis and etiology of infertility, and treatment for the diagnosed conditions. All are necessary components of care. In the United States, 1 in 8 couples has infertility, which is calculated from 12% of American married heterosexual women stating that they have ever used fertility services. However, 1/4 of those who need treatment may not have access to assisted reproductive technologies to conceive. Between 2015 and 2017, almost 10% of US women reported that they sought care to achieve pregnancy. However, less than 1% reported ever using assisted reproductive technologies, or ART. ART accounts for a much lower percentage of live births in the US than in other countries. Here is a comparison between the US and Europe overall, as well as select countries which have more than double the rate of ART usage than compared to the US. When compared to other contemporaries such as Canada, the United Kingdom, Japan, and Australia, again, we sorely lag behind in ART utilization. As you can imagine, the underutilization of ART is closely linked to the cost of treatment. This graph is almost the inverse of the one I showed before it. The United States has the highest cost for IVF, as well as the highest cost as a percentage of our gross national income. A single cycle of IVF may represent up to 50% of an average American's annual disposable income. Although it varies by region and state, the cost of IVF ranges from $9,000 to $13,000 for a basic level treatment. However, this doubles to up to $25,000 once the cost of medications, laboratory fees, and options for embryo handling and testing are included. Compounding the high cost of treatment is the reality that many patients will complete more than one cycle during their process to achieve pregnancy. While this graph focuses on IVF, many patients have undergone surgeries or medication or insemination cycles, which also incur a cost. The cost of infertility care is often discussed because it's not often covered by health insurance. So much so that discussions of out-of-pocket treatment costs is very common in our field. Think about it. We never discuss the cost of a hip replacement surgery or appendectomy because these are frequently covered by insurance. As of July 1st, 2021, only 19 of the 50 US states provide an infertility mandate to say that employer-provided insurance plans in that state must offer infertility coverage. However, what is covered differs from plan to plan and state to state. And within those 19 mandated states, only 5 have IVF specifically included in the mandate. What is not appreciated is how much infertility care remains uncovered, even in mandated states. Many persons are excluded from treatment due to stipulations like the size of the company they work for, religious exemptions, age limits, and sometimes circuitous rules regarding the definition of infertility. Therefore, the cost of treatment and the lack of insurance coverage leads to less access, lower utilization, disparities, and low public health knowledge. Considering how to expand access to care, cost is typically the most commonly cited barrier to care. But for those of us who study access, we know that this is only the tip of the iceberg. Additional and often additive factors to consider include health disparities, equal access to services, eliminating public and provider bias, and acceptance of infertility as a disease. At the core, disparities in comprehensive obstetric and gynecologic care contribute to disparities in infertility. Disparities in infertility are somewhat overlooked, even as an awareness of other reproductive disparities grow, such as maternal mortality, a history of forced sterilization, and even access to abortion care. Infertility disparities must be discussed in the full spectrum of reproductive care. As compared to non-white women, non-white women are half as likely to present for care, have a longer duration of infertility at entry to care, have a lower utilization of effective treatments, and higher rates of treatment discontinuation, as well as poorer outcomes even after treatment is initiated. What is lost is how infertility is an additional disparity that even precedes pregnancy. And START data has shown us that clinical pregnancy and live birth rates are lower in Asian, African American, and Hispanic women, and African American women have a lower live birth rate, and higher spontaneous abortion rates than Caucasian women following autologous IVF cycles. The social and cultural impact of infertility may be magnified in immigrant communities. Here we've seen that involuntary childlessness can lead to isolation, abandonment, and even contribute to domestic violence. And therefore, we have to have careful attention to the experience of infertility in these communities. Further, income, education, and private insurance only partially mediate the relationship between race and treatment utilization. We've seen here that significant cultural and social factors play a large role in the decision to pursue infertility treatment and can contribute to extreme distress caused by childlessness. African American and Hispanic women report difficulty finding a physician with whom they feel comfortable, difficulty to get treatment due to their race, and are more likely to be referred by a family friend or family member or to be self-referred than white women. Thus, minority women have a more difficult time navigating care due to provider interactions, perceptions about how they are viewed due to their race and income, and inability to either find or connect with providers. No data exists to assess the racial composition of practice in REIs, but from recent trainee data, it's estimated that diversity is lacking in the field of REI, despite overall increases in diversity in OBGYN overall. We know that from disparities research, physician sex and race concordance is something that's noted to improve patient outcomes, in largest part due to patient experience and comfort in their provider interactions. So new efforts to diversify our subspecialties should take top priority. In fact, the ASRM noted the need for diversity in our field and want to promote underrepresented minorities in professional leadership as part of one of the charges of the ASRM Diversity, Equity, and Inclusion Task Force. Created in June 2020, the task force seeks to identify ways to address and measure progress towards these two charges, enhancing opportunities to increase and support diversity and equity, as well as reducing and eliminating health disparities overall. OBGYN training programs provide opportunities for direct care of patients from underserved groups who may not otherwise have access to reproductive care. And academic medical centers that train OBGYN residents often serve as primary access points to healthcare for underserved communities. In addition, many institutions intentionally include care for the poor or underserved in their institutional charters or state mandates. Today, we will discuss why OBGYN training programs are uniquely poised to expand access to infertility care, and how this actually serves as both a necessity and a benefit to both the populations being serviced, as well as trainees who are learning the breadth of care of women throughout the lifespan. Now I'm going to hand it off to my colleague, Dr. Holly Mayer, who will discuss improving access to care through education.
Thank you for that introduction, Dr. Jackson-Bay. Today, I will discuss improving access to care through curriculum creation. As Dr. Jackson-Bay outlined, the staggering disparities in fertility treatment in the United States can be overwhelming. As trainees and educators, one of the components we have control over is the REI training and education within our own institutions. And resident education in REI is particularly important for several reasons. First, training in reproductive endocrinology is very important for future general OBGYNs. As we discussed, infertility affects 1 in 8 women and is one of the most prevalent diseases of the reproductive tract. As we learned, there are significant unmet need for infertility diagnosis and treatment, and generalists who have been well trained can offer much to the workup and even some treatment for these communities. REI exposure among diverse patient populations can help solidify resident decisions about pursuing fellowship, and this is also important for recruiting a more diverse REI population. Unfortunately, there is wide heterogeneity and substantial gaps in REI training among OBGYN residency programs. In one survey, they found that nearly 40% of OBGYN residents nationwide perceive their REI knowledge to be poor. What's more, many training programs lack any training in fertility care to underserved communities. So the question is, are we learning to treat the patients that need to be treated? Residents are often primary providers for medically underserved populations, and with the proper resources, they have the opportunity to make huge impacts on the fertility care available in their communities. Although not commonly thought of as access to care, residents can directly participate in and provide care to patients from disadvantaged groups who may otherwise not have access through trainee-run clinics. Such clinics are also an educational opportunity. These trainees will have the benefit of learning in a spectrum of settings, which will expose them to how infertility can present in different sociocultural settings, and they will also learn different methods for managing infertility in lower and higher resource settings. What's more, the resulting clinical experience and training will better prepare graduates to provide care for their future patients. And finally, many of the graduates will continue to educate trainees in their career, so expanding REI education can lead to an exponential increase in knowledge for future generations of OBGYNs. The training to provide care can and should take place in 3 domains of training: didactics or classroom-type learning, clinical training through resident clinics, and via advocacy. Today, I'll be focusing on the creation of the didactics portion of their exposure, and we'll discuss the other areas in subsequent segments. Let's start by discussing the components of a program that should be included in an access to care REI didactics curriculum. They include a values clarification discussion, which we will discuss, information about the disparities and barriers to fertility care, bias and cross-cultural training, core REI knowledge training, which is clinical tools for the reproductive function and diagnosis and treatment of infertility, and clinical tools for practicing in lower resource settings, which will be discussed by Dr. Christ, and training for advocacy, which will be discussed by Dr. Vu. In the interest of time, I will discuss some of the components briefly with the sole intent of pointing out some of the many resources that already exist to help you create your curriculum for your institution. You can find an expanded list In the handout that we provided, if you look at the control panel on the right side of your screen, you should see a tab for handouts. You can click on that to download a PDF with many resources of these in these different categories that we have compiled for you. Then after we go through this quickly, I will focus a bit more on the component of values clarification. So learners should be made aware of the extent of barriers to care, as well as healthcare disparities in fertility treatment. There are several resources that exist and are available via ASRM, including written documents, as well as several access to care webinars. Again, there are links to these resources on the handouts provided in the control panel. Residents and other trainees need a solid training in the clinical aspects of diagnosis and treatment of infertility. There are many resources available through ASRM, including 10 resident-specifically targeted error learning modules, as well as reading and CREOG resources via SREI. And quickly, I just want to make one plug for this problem-based REI learning curriculum that is available on the AAMC MedEd portal. This is a fully formed curriculum that's wonderful, and we've provided the links for all of these resources listed in our handout that's again found in the control panel. So now let's discuss a little bit more what we mean by values clarification. And to do that, let's start with a polling question. So let's have our attendees consider their thoughts on the following question. For which of the following patients or couples do you think IVF should be available and covered through health insurance? I think we're going to allow about 15 seconds for your answers. Please choose an answer on the screen that has popped up. I love this story. I love our results here. So let's discuss the role that values clarification can play in this question, and we'll return to these results in just a minute. So you may have heard of values clarification through the field of family planning, which often facilitates a values clarification discussion for the provision of abortion care. It's generally an exercise in how our own personal values influence the way that we as providers interact with women seeking abortion. And there are similar potential values conflicts that come up as we treat women attempting pregnancy. Such exercises begin as a facilitated conversation about what patient care situations specifically make us as providers feel uncomfortable. On the surface, it may seem that there are fewer biases or conflicts that come up with fertility treatment than with abortion care, but let's just take a step back. As a society, if we truly believed that everyone has a right to become a parent and to create a family, and we truly believed that infertility was a disease, we wouldn't need a conversation about improving access to care because it would be a priority and access would already exist. Why do we even need to have this conversation today? Why is reproductive health and fertility treatment not a priority in our healthcare system? I would argue, and I think others would as well, it's because there are biases that we all carry about who deserves access to fertility care. And we need to ask ourselves about those assumptions we're making if we're going to provide care for women who are seeking our advice about pregnancy. So some common assumptions and biases that we make as providers could be, for example, the age at which someone should be attempting pregnancy or seeking treatment for infertility, the number of children one person should have, or whether those who already have children should be treated for infertility, whether women should become single parents or couples should attempt pregnancy when they're not married, the fitness or desire for LGBT individuals to parent, the ability of someone from a low socioeconomic status to raise children, whether someone with a history of previous terminations could have infertility or should be allowed to access fertility treatment, and the fitness of someone to have children when they have an incarcerated partner. This is just a few examples of biases that we may carry, and I want you to take a moment to consider whether you carry any of these values or assumptions. Now, let's return to our previous question. Ask yourself what assumptions you made about why any of these women should or should not have access to care, and the values that we have imposed on our own patients. The first patient, for example, is lower income. Many of us would question whether lower income women have an ability to afford to care for another child. But let's also remember that there are a diverse array of circumstances in which people provide for and raise their children. And additionally, I would argue that American physicians are some of the wealthiest people literally in the world, and our judgment of whether someone has an appropriate financial situation is likely heavily biased. This patient also has had a history of a tubal ligation. We often think of tubal ligation as an elective procedure, but in many settings, it may not be something that the patient has fully consented to. And we should know that even in states with IVF mandates, many will not cover IVF after a tubal ligation. This patient is also an immigrant. Many of us hold implicit bias around the rights of immigrant communities to access care and to have children that are born in the United States. Additionally, we should acknowledge that we may not comprehend the impact of fertility in patients that are coming from lower resource communities or those that are coming from different cultural backgrounds. It is not the same to experience infertility as a white or wealthy American compared to potentially to those who are immigrants or coming from lower resource settings. It is likely that we do not fully understand the cultural meaning of parenting or fertility among various immigrant patients. The second scenario has a patient who already has 3 children. Some providers may hold views of what is appropriate family size may be, but who's to say that we as healthcare providers have the ability or right to be gatekeepers for such a personal decision as the number of children one has. Additionally, some may hold assumptions about a patient desiring children after remarriage. Tubal ligations, we know, come with some degree of regret. This is well known. Additionally, this patient could be feeling pressure from her partner or her in-laws. And as a provider, denying this patient care does not help any such scenario. So I hope this exercise illustrated a little bit about how our own predefined beliefs about family building can influence our professional judgment. It also can influence the patient-doctor relationship and the quality of care that patients receive. So the next thing to think about is how can we move beyond our own personal assumptions and develop empathy or compassion for those who we treat? We can ask ourselves, are there aspects of the patient's life, their experiences, beliefs, values, or culture that help us understand their behavior? Or ask ourselves, regardless of our personal views about family building, what is the professional obligation that we have to counsel patients about their options? As healthcare providers, it's our duty to provide patient-centered care and to separate our personal feelings from the care we provide. And that is the point of a values clarification conversation. In our handout, we have shared several resources for facilitating values clarification exercises. These are resources that are from the family planning literature, but again, we do feel that there is significant overlap with the potential barriers to care for patients in the fertility setting. And next, I'll pass it on to Dr. Jacob Christ, who will discuss how we can develop skills to decrease cost for our patient.
Great, thank you, Dr. Mayer. I'll be describing ways clinics and training programs can improve access to fertility care for underserved patients. So who are the underserved? Well, currently racial minorities, patients with lower income, LGBTQ individuals, and immigrant populations are some of the main groups who do not have adequate access to fertility care across the US. Lack of access to fertility care has a significant impact on these communities. I will focus primarily on immigrant populations whose experience with infertility often parallels the struggles faced by patients in developing countries, as is described in this 2008 study. The family unit often provides significant cultural and financial support among immigrant communities. Thus, an inability to have children has multiple levels of consequence, ranging from level 1, psychological distress, to level 5 and 6, physical threats and loss of value in self. As an example, a woman in our clinic who had immigrated from Vietnam was ostracized by her community and was physically abused by her husband and his family after being blamed for their infertility struggles, despite her husband refusing to get a semen analysis. Stories like this are unfortunately not unique. We are operating in an imperfect world, but we owe it to these underserved groups to try to provide the best fertility care possible within the constraints many face. Immigrant communities often face unique challenges to accessing fertility care. This is data adapted from a study comparing patients at the San Francisco General Hospital's low-resource infertility clinic, which primarily sees women who have immigrated to the U.S., and a high-resource fee-for-service clinic at UCSF. Patients at San Francisco General were primarily non-white, few had English proficiency, and only 2% had a household income greater than $50,000. In this study, they looked at the relationship between education and income level on duration of infertility as a proxy for access to care. They found that the less educated and the lower the income, the longer duration of infertility, and thus the lower the access to care. So why do these patients have poor access to care? Well, they face unique barriers, some of which we've already discussed, which can be prohibitive if not addressed. Before patients can even be seen in a clinic, they need to navigate the challenging US healthcare system. For infertility clinics, this is especially problematic as patients need to schedule multiple appointments, ultrasounds, timed lab draws, and handle complex insurance issues. If able to be seen by a provider, communication issues are consistently cited as a major barrier to care. This includes language barriers, but also disparities in medical knowledge, which when combined create significant challenges for clinics and their patients. For those who ultimately pursue treatment, cost remains one of the largest barriers to care. 19 states have infertility insurance mandates. However, many do not qualify for coverage, even in mandated states, and utilization of mandated medical coverage varies greatly across racial and socioeconomic groups. Finally, as Dr. Mayer discussed, providers frequently have false perceptions and implicit biases, which result in poorer care for their patients and ultimately create disparities in care. Luckily, academic medical centers are already poised to be centers of care for underserved populations. We argue that a key tenet of this care must include resident and fellow education. These centers are already the primary location for graduate and postgraduate medical education, and thus they have the opportunity to integrate trainees into their practice. Furthermore, academic centers are typically mandated to provide care to underserved populations and have clinics located within underserved communities, allowing them to be major access to care points for underserved patients. As such, many centers already have an established infrastructure of resources, such as translators, transportation programs, and financial counselors. Regardless of location, there are several strategies which clinics can use to help overcome these barriers. Most clinics already have access to interpreters. These can be combined with printed clinical information sheets and patient instructions translated into the main languages seen at your clinic. Basic strategies like drawing out anatomy diagrams help patients understand their diagnoses and treatment options. For an example, at our clinic, we had a woman with a history of bilateral self-injectomy who presented after attempting to become pregnant with unprotected intercourse for 6 years after her self-injectomy. No one had ever drawn out the anatomy and explained how her prior procedure impacted her ability to become pregnant. Patients should also be provided transparent information on costs and outcomes of treatment without assuming what a patient may or may not be able to afford. Many times, patients with lower socioeconomic status are not offered IVF. However, assuming patients cannot or are unwilling to pay for these treatments is biased and again ignores the significant impact infertility can have on these patients. Many are willing to use savings or take out loans to pay for treatment, given the importance of fertility in these communities. Clinical care in these settings must also be optimized in order to improve patient outcomes and reduce costs. Diagnostic protocols should be standardized across providers with clear documentation of workup and diagnoses. Patients often go from provider to provider and have duplicated evaluations of some tests, while other critical evaluations are never done. It's also imperative that patients and their partners have access to HSG and semen analyses or referrals for these programs. While 30% of infertility is male factor, women are disproportionately blamed for infertility, which not only hinders adequate care, but also causes significant stigmatization and discrimination against women. For those with a diagnosis, ovulation induction can also be offered to women with PCOS without requiring referral to an REI specialist. Care paths should be standardized across providers to ensure high-quality, evidence-based care that is also cost-effective. Finally, there are medication discount programs which should be offered to those patients that qualify. I will next discuss some approaches to ART, which have been suggested to reduce costs. Before I do so, I wanted to poll the audience to find out if your clinic has options for reduced cost fertility care. All right, well, that's great. I'm glad to see that a majority of people already have options for a reduced cost program. Hopefully, I can provide an overview that can serve as a useful starting point for those clinics that don't have any options for low-cost infertility care. In brief, several mild stimulation protocols have been suggested with the aim to reduce the cost of treatment by lowering the amount of medication used. Across these strategies, there is still debate about what protocols are optimal, including what oral compounds to use for stimulation, the benefit of adding low-dose gonadotropins, and whether and which agents should be used to block ovulation. The application of these protocols is feasible. In 2010, the UCSF Fellowship developed a program to provide increased access to infertility care at the San Francisco General Hospital. This fellow-run clinic used a combination of these mild stimulation protocols to provide infertility care at a low cost. Here you can see the different protocols offered at this program. While I won't discuss each protocol individually, overall, with the utilization of these mild stimulation approaches, and again, in a fellow-run clinic, a live birth rate of almost 50% was achieved. Which protocol to use must be individualized by each clinic and for each patient. While these strategies can reduce medication costs, at least half or more of the costs for ART are from the lab component. Intravaginal culture is a potential method for reducing embryology lab costs. In this system, there is direct incubation of the sperm and oocyte or embryo after ICSI in an intravaginal culture. I present data from a 2016 randomized control trial comparing intravaginal culture with traditional IVF, which showed overall similar clinical pregnancy and live birth rates between the two strategies. I want to end by returning to a discussion about the importance of integrating trainees into clinical care and start by asking the group if trainees currently work in your clinics. That's great. It's awesome that already a majority of clinics already have trainees involved in the care. It's really important to include trainees in clinical practice. And as Dr. Mayer discussed, unfortunately, resident training in REI really varies greatly between programs and across the country. Trainees need this direct clinical exposure to REI in order to feel comfortable providing infertility diagnostics and initial treatments after graduation. Many women don't require IVF for management of their infertility. If more graduating OB/GYN residents felt comfortable with initial infertility workup and treatments, access to care could be greatly expanded. The involvement of fellows and residents in low-resource settings is also important to provide exposure to how infertility impacts people across sociocultural demographics. Furthermore, it provides fellows with the opportunity to function autonomously, provide mentorship, and learn new skills and management strategies that may otherwise not be used at traditional high-resource clinics. Overall, incorporation of residents will lead to improved access to care and reduced health disparities. As an additional example of a program incorporating residents and fellows into clinical care, I present the low-resource infertility clinic located at NYU's Bellevue Hospital, which tightly integrates residents and fellows into their practice to help reduce costs. Their model could be used as a framework to create programs at institutions not currently utilizing residents and fellows. In summary, infertility is a major public health issue. This disease has profound impacts on underserved patients that can have lifelong consequences if not addressed. Unfortunately, these patients have immense barriers to care. We propose that academic medical centers can serve as important access points for underserved patients. We recommend several strategies to help reduce barriers to care for low-resource patients and provide methods of improving care for this population. Ultimately, the incorporation of trainees into this care and an increased focus on REI training, which includes fertility care for the underserved, is critical to broaden access to care and improve trainee education. So I thank you for your time, and I'd like to introduce Dr. Vu, who will be discussing REI advocacy.
Thank you, Dr. Christ. I'm going to close this presentation out with a discussion of fertility advocacy. As trainees, I believe there's a lot of discussion around advocacy. We are constantly told you need to be a good patient advocate, but we are often not given the training and resources to be good or even great advocates. Let's start with the definition of advocacy. Advocacy is defined as the application of information and resources to effect systemic changes that shape the way people in a community live. Advocacy encompasses a broad range of activities, including research, public education, and lobbying, all of which can influence change. Research has shown time and time again that scientific evidence on its own is not sufficient enough to bring about the changes in policies and services benefiting patients' healthcare. Change is made in the setting of public readiness. This is why it is so important for physicians to be vocal about the issues they are passionate about. There are many reasons why physicians and physician trainees are great advocates. We are often seen as leaders in our community. Citizens as well as lawmakers value our medical knowledge. Additionally, healthcare workers spend every day with their patients. We should share our experiences firsthand. So how can trainees get involved in infertility advocacy, and how can we work to integrate advocacy into our residency curriculums? Advocacy involvement is easier than you would think. As mentioned earlier in the presentation, patients of color and uninsured or underinsured patients are often funneled into resident clinics. Residents have a lot of experience with our underserved patient populations and thus are in the perfect position to share their stories. For instance, I distinctly remember a Medicaid patient in my continuity clinic who had 5 biochemical pregnancy losses and was no longer able to afford REI care. She had maxed out 5 credit cards and was unable to pay her rent or buy groceries. She was also in the process of separating with her partner as the stress of seeking and paying for infertility treatment had put a strain on their relationship. This is the story I told at Resolve's Advocacy Day. Speaking of Resolve's Advocacy Day, this is an awesome and easy way for trainees to get involved in infertility advocacy. Every year, Resolve, the National Infertility Association, and ASRM partner together to hold this Advocacy Day. They work to coordinate meetings for participants with their local, state, and federal legislators, and they also provide participants with the training and resources to empower them to make their voices heard. Infertility advocacy does not have to be this daunting feat. You can join the groups already doing it. I know I have, and it makes big, bad, scary legislators seem like normal people who care what you have to say. We, of course, have to talk about infertility advocacy through social media. Social media has become a hot spot to discuss disparities in infertility care. In April 2019, over 3 million images related to infertility were noted to be posted on Instagram. Many of us also know Natalie Crawford, shown on the far right image here, who gave a presentation about social media at the 2020 ASRM conference. She is the perfect example of someone who uses her social media platform to spread factual information about infertility and also provides her followers with tangible steps they can do to engage in infertility advocacy. Moving on to how we can incorporate infertility advocacy into trainee curriculum. In this new era of medical training, professional societies are beginning to understand the importance of advocacy. The AAMC recently published a statement highlighting that advocacy must be ingrained in the profession of medicine. They state, if advocacy is a professional imperative, its competencies must be well defined and all physicians must meet them at some basic level. These competencies must not be relegated to a new specialty called advocacy. Whereas a minority of doctors practice cardiology, every physician must understand the circulatory system and its place in his or her clinical area of expertise. So it should be with advocacy. As of 2017, only 4 years ago, ACGME required advocacy to be a learning requirement for all residency programs. The Council of Resident Education in Obstetrics and Gynecology, better known as CREOG, was a little ahead of the ACGME curve as advocacy was introduced in the 2012 CREOG educational objectives. They stated that the objective was to advocate for the patient, women's health, and the profession of obstetrics and gynecology. The issue is that there is typically no formal advocacy curriculum in the majority of OB-GYN residency programs across the country. There are ways that we can help develop these curriculums, and there are a handful of resources to help in this curriculum development. I'm just building on the curriculum that Dr. Mayer, had already mentioned earlier in the presentation. ACOG has developed some advocacy modules, and ASRM has published an advocacy toolkit specifically for REI advocacy. The literature currently reports that GME level advocacy curricula is primarily found in primary care specialties, most commonly in pediatrics. It is also noted that the curricula varies broadly across programs, with some focusing on community partnership and others focusing on legislative advocacy. Overall, though, the studies assessing these advocacy curriculums conclude that residents report improved knowledge, attitudes, and self-efficiency, around advocacy. Advocacy curriculum does work. As we all know, there are many barriers to the implementation of advocacy into residency's core curriculums. Trainees are already tired and overworked, and there are other curriculum demands and countless other educational objectives. There also needs to be faculty and mentors who are passionate about teaching advocacy. This is why advocacy needs to become a formal part of the curriculum, not just an extra or an elective. It is clear that we need to work towards integrating formal advocacy curriculum into residency programs, but more specifically, infertility advocacy in REI rotations during OB-GYN residency. This will allow OB-GYN trainees to better understand the issues their REI patients face and how we as physicians can advocate for better care. I want to close this presentation out by thanking Dr. Christopher Herndon for being a trailblazer in the REI Access to Care movement and bringing this wonderful group of speakers together. Dr. Jackson Bay, Dr. Mayer, and Dr. Christ, it is a privilege to be able to speak alongside you three. And to our audience, thank you for allowing us to use this platform as we work towards dismantling the barriers to REI care. We hope we gain some advocates here with us today. I'm going to pass it off to Dr. Herndon so he can lead the question and answer session.
Thank you, Dr. Vu, and thank all the speakers for fantastic presentations, so comprehensive. To our audience attending members, you can please feel free to send some questions for our panel. I will start off with the first question for Dr. Jackson Bay. Can you speak to the role of insurance coverage for IVF in improving utilization for racial and ethnic minorities? What challenges and barriers still persist even for insured patients with respect to accessing care and treatment outcomes?
Yes, insurance coverage of infertility evaluation and treatment is a huge consideration when reducing the issues in access. We've been able to look at, the differences between mandated and not mandated states. And yes, there is going to be more access in mandated states. However, there still remains some barriers, despite having insurance coverage, that, keep certain groups at a disadvantage. And, as I mentioned, sometimes it's the location of REI practices, typically primarily located within cities, and may not be distributed equally across the states and across different suburban or rural areas. Also, I think, even though insurance may be available, not all practices take insurance or take all insurance plans. We've seen, in all of our practices, stipulations between what is and what is not covered by insurance companies. One of the things that I find most frustrating is when the evaluation is covered, but treatment is not. So we led you all the way up to this certain point just to say, sorry. And so that's something it's really important to, consider, is that, yes, it is a fundamental first step that insurance should, include more infertility care, not just the care, but evaluation as well. But it's not the whole picture. And so we talked a lot about, bias, about, I just love Dr. Mayer's presentation about goals clarification and values clarification, because I think that really speaks to a huge elephant in the room, so to speak, in our field, about who is worthy of being a parent and having and benefiting from our services and who is not.
Thank you. I can't agree more. With the second question is for Dr. Mayer. At some OB/GYN programs, residents have limited clinical exposure to REI practice. What recommendations do you have in which these residents can help strengthen their education and training in REI so that they feel more comfortable providing infertility care when they go out to practice?
Thank you for that question. That's a good question. I think one of the important things to think about is, if for the residents that are listening, is to consider yourselves potential advocates for your own education. And many program directors and the people who are coordinating your education are very busy. They have a clinical practice, and not all, but many of them are generalists. So they may not have a comfort or connections with REI, the REI community. And so I think going to your program director first with sharing your interest in disparities and bringing with you the CREOG requirements for advocacy and also for REI learning in those learning objectives, I think can be helpful. And also, offering the resources that already exist. A lot of times the barriers in terms of just getting the educational clinical component down, the didactics component can be a barrier in the time it takes to put something together. So coming with those resources, coming with your interest, and if you, another really important thing I think specifically in didactics resources is if your program has an education chief, go to them. And if you don't have an education chief, consider creating one. Because I myself was the education chief, and I really felt like it gave me and it gave the residents a place to come that was very accessible for their interests in learning, and it gave me a real sense that I had some control over what we were learning during my residency education. In terms of clinical work, I mean, I think that there probably are, depending on where you're located, there probably are REIs who would be interested in having a relationship with the university and creating a resident-based clinic, but it's just, there's some inertia in creating that. And so it takes a lot of work, but if it's something that you're passionate about, I know that there are people that wish that they were more involved with improving access to care in like university-based clinics. So that's another thought.
Those are great thoughts, Dr. Merritt. Thank you. Our next question is for Dr. Christ. You spoke about some of the challenges encountered in providing infertility care in resident continuity clinics. In your experience, what do you think are the best approaches to improve non-ART infertility diagnostic and treatment services in residence clinic? Do you recommend setting a dedicated REI clinic? If there is not one, how can residents best provide infertility care to underserved patients?
Yeah, I think that what can be hard is that if you are in a continuity clinic where there isn't a structured infertility program, you're working with different generalist attending staffing your clinic, and if you don't have experience providing infertility care, then it can feel overwhelming or feel very challenging to provide the initial infertility workup and treatment, even though many of these strategies can easily be done in a normal residency continuity clinic. So having set protocols, I think that can be used across your hospital system and across your program for both workups of infertility and then also treatment protocols for things like ovulation induction with letrozole and clomiphene, how to monitor patients, what kind of imaging tests to be getting for patients. Just having those types of protocols formalized and even like printed out inside of your resident workroom, so that way everyone just has easy access to those, I think makes it much more accessible and people feel more comfortable providing that kind of care. And then it allows nursing and the other staff that's working there to also be able to help residents more. Having a dedicated REI resident clinic is awesome because then, especially if you're working with REI faculty, you get to have that direct mentorship. So you get to have a lot more hands-on experience. And so I think that's a wonderful experience if residents are able to set that up in their program. But if not, kind of like Dr. Mayer was saying, looking for opportunities with either REI faculty within your own program or within your local community. There are lots of people that are interested in having residents be involved and then figuring out ways that you can get involved and help broaden access to care through your involvement, I think can be helpful.
Great, thank you. Those are some great kind of concrete ideas that tools that clinics can do to improve their fertility care. We're almost at the close of our session, so I want to have the last question go to Dr. Vu. It is an unfortunate reality that many medical students, residents and fellows, as well as support staff in academic medical centers cannot afford to access infertility treatments or fertility preservation services that they help support care to. What can one do as a trainee to help bring change and equity?
That's a great question, especially because when we think of people who can't afford infertility care, often we think of, the people on public insurance or people who are uninsured, but a lot of healthcare workers and trainees don't have access or cannot afford this care. And I know that I see it in with my colleagues all the time in my own personal experiences in my residency program. I think that goes hand in hand with advocacy. Advocacy occurs at many different levels, of course, so talking to employers or even program directors, but then also engaging in advocacy at the state level or participating and talking to federal legislators. I think getting that message out there that it not only affects people who have no insurance or who are underinsured, but also people who have insurance, it's just not covered through other forms of private insurance. And I think that's another really important part of advocacy, is that there's a whole broad spectrum of fertility coverage, and we want everyone to have equal access to care.
Great, thank you so much. We're at the close of the hour. I wanted to thank our panelists for such wonderful presentations and discussions, and all the insights and perspectives that they shared. I would like to thank our attendees for joining us, and I'd like to thank Sarah Remayan and the American Society for Reproductive Medicine for organizing and supporting this webinar.
Thank you, Dr. Herndon. Thank you for moderating such an engaging session, and thank you to our panelists, a fun group to work with. Thank you for bringing such a timely topic up for discussion. And to the attendees, thank you for joining us. You will receive a survey right after this session and by email after this session. And your feedback helps us give you the most relevant content, and your input is appreciated. If you are interested in volunteering at ASRM, please take time to fill the volunteer application, which is attached to the survey form. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. And for any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar. Thank you.